So the patient reported worsening weight loss and fatigue and just sort of general failure to thrive. And again, a CAT scan was done which showed progression of disease. So in this case, the patient had new lung nodules. So we have liver nodules, lung nodules were clearly in a palliative setting. So the question becomes what therapy was given. And in this case, irinotecan and cetuximab was chosen. And the patient seemed to have some benefit with that, with some stable disease on the first restaging scan. The patient was switched to irinotecan and cetuximab, and then a PET-CT was obtained 3 months later, which showed stable disease, and overall the patient seemed to get some symptomatic benefit for about 3 to 6 months after starting the therapy. So the patient in this case did somewhat better than many patients do. So the time to progression or progression-free survival in the second line setting is shorter than the first line setting. And that makes sense, right? If a cancer is getting resistant to one type of chemotherapy, for instance, drug efflux pumps, or they're turning off apoptosis pathways or what have you, it stands to reason that they're going to be more resistant to whatever you choose second line. So the benefit in the second line setting is often less than the first line, and that's really true across multiple cancer types. So a fairly typical story here. The patient got second line therapy, did okay for a while, and now is progressing. So you're thinking about what are the options in the third line setting, and in fact you have multiple options to choose from. In this case, a combination between a cytotoxic, irinotecan, and an EGFR inhibiting monoclonal antibody with cetuximab. You could have also chosen panitumumab, was chosen. One could argue, well, having a cytotoxic in the third line setting, that might be a little much, the irinotecan. And also the patient got worse on FOLFIRI, which has irinotecan in the first line setting. But there is something about those two drugs, they seem to synergize pretty well, irinotecan and cetuximab. So if the patient has a good performance status and you think they can tolerate it, it's a very reasonable option. You'll note that in this case, a PET-CT was obtained after chemotherapy to look for response. And I just want to make a note that in general, getting PET-CTs to look for chemotherapy response is not in most of the guidelines. There's definitely a role for PET-CT. We use it anytime we're going to do surgery to make sure there's not occult disease somewhere. We use it when we're going to do radiotherapy, for instance, because we want to make sure that there's nothing hiding. We often use it for initial staging. But once someone is on chemotherapy, getting PET scan after PET scan, it's not only much more expensive, you're also exposing them to a lot more radiation. And so most of the guidelines will tell you you really shouldn't be using that to determine the response to chemotherapy. You should be sticking to CT scans and use PET scans for those other things that I mentioned.